Hello, thank you for coming. This is Ruth Myers talking about medical influences on people's behavior. There's a bunch of different ways it happens. We talk a lot about it. Well, has this person got a medical issue going on? And I wanted to talk in a little bit more detail about that, and also talk a little bit about some of the issues we run into trying to get help to identify and get relief for people that have those kinds of health problems influencing their behavior. I've been coming back and forth to California for a number of years now. I think the first time I consulted here was about 25 or more years ago. And I've noticed a trend in the last several years, maybe you've seen it too, where a certain subset of applied behavior analysis is being kind of applied to everything going on with everybody. And in California, there's more access to traditional certain type of traditional applied behavior analysis support than any place else in the known universe. So that being the case, how is it that a person could get into a behavioral crisis and stay there, even though we've got more ABA opportunity around here than we know what to do with? And just a kind of a side note on BCBA, behavior analysis type of people. About 20-something years ago, I was forced to work with somebody who was more of a traditional ABA guy, PhD in applied behavior analysis, trained at Kansas University, the mecca of applied behavior analysis, with the godfathers and godmothers of applied behavior analysis. And I'd always worked with behaviorists that were more positive behavior supports people. So being forced to work with this guy was like, oh man, this was like a big project in another state, trying to settle a 30-year lawsuit. And, he pretty much said for all the world that all psychiatrists, that would be me, are just complete idiots, and all they want to do is drug people up. And so, he tried to teach me about what's all good about applied behavior analysis. And we argued and yelled and shouted, and then 3 years later, we were married. So we have a lot of opportunity here at STEP because that guy, Dr. Steve Myers, is in fact the most credentialed, experienced, and successful full spectrum behavior analyst currently practicing in the United States. And what he teaches about the proper implementation, the potentially life-saving, life-changing proper implementation of applied behavior analysis is quite a bit different than what I'm going to talk about with this particular example of a fella named SD, who was 19 when I first met him. He is a giant guy with autism, 6'3" then, he's 6'5" or 6 now, who had absolutely destroyed the family home. Very nice home, very nice California home, very nice family. One of those loving, devoted families that never gave up, even though they were scared to death. They'd all fled. His parents had not had any time, just the two of them, for even a dinner, much less a vacation, for about 18 of the 19 years he'd been alive. They would trade off staying in the house with him, whereas the other parent would stay someplace else, and all his siblings had fled. The house was completely destroyed, and he'd been getting traditional 6 to 8 hours a day applied behavior analysis programming every day at home and at school for 10 years. And the result of that, and these are pictures from the internet, as a matter of fact, they are not pictures of his exact home, but they look like what his home looked like, covered with blood and ink and feces, and the walls were destroyed, and there's only so many times you can put a wall back together. Objects destroyed everywhere. It was a complete epic failure, and he was becoming more and more destructive. He was also quite violent to himself and other people, punching, shoving, headbanging, biting, every kind of aggression you could imagine, plus blood-soaked feces distributed everywhere throughout the house. Still, there was one observation made by a very, very good teacher at the school, which is that when he was in his big, gigantic swing in the classroom, he learned better than when he was seated still. That turns out to be important, turns out to be a clue. Oh, this fella, some of you probably know him. He, at that time, had no speech, no sign, no written communication. So he communicated entirely without words. A few years ago, before I'm meeting him for the first time, when he's 16, he lost 60 pounds, binge eating and vomiting, binge eating, vomiting. The behaviorist who'd been working with him and worked with him all those 10 years said that the mother shouldn't give in to worrying about that, that it was all just manipulation. He's just trying to jerk you around. Just stay with the program. If you guys were better at implementing this behavior program, this would all go away. When he started vomiting gobs of blood, his mother said, "All right, I'm going to rebel, and I know it makes me a bad parent, but I'm getting some help." Well, she got a GI specialist, and it was discovered that this man had a belly full of hemorrhaging H. pylori ulcers, and he was very close to bleeding to death. This cracked the window of thinking there might be more to him than autism and so-called bad behaviors. In addition, the things that were being leveraged in his behavior program was that he liked to eat dozens of popsicles a day, like dozens and dozens, full sugar popsicles. And of course, the kind of a certain type of behavior analysis thinking was, well, we should make him work for him then, if he likes them. So do this task, jump through these hoops. And after about 1 or 2 rounds of that, this man would just go tear the freezer off the wall and get the stuff himself. He sometimes dug at his rectal area, and he sometimes would hold his head and look kind of sad. Well, does that sort of make you think there may be more to this than just disobedient behavior? Obstacles. What are the obstacles that are in place? Well, for one thing, people get very caught up when somebody's activities of concern are violent or destructive, don't they? I mean, people get mad, they get resentful, they get tired, they get hurt, they get, like, not very sympathetic to, oh, what could be troubling you? But in fact, that's where the action is, isn't it? The big obstacle here was that, there's been a number of cookbooks published that are supposed to be the key to how you manage people with autism. And the subtext is, if you're a good parent, you will do this. If you don't do this, you're a bad parent. And that's not fair, but it is the message that's being pushed, isn't it, on a lot of the parents that we try and collaborate with. You have to follow this book or you're a bad parent. So continuing to do things that don't work, which in the case of this man was ABA, because we think they should work. And that's part of the reason why it's so critically important to collect data that means something. Because if we're taking up a person's time and energy with something that doesn't help, we got to stop, right? Do something else. Ignoring people when they report pain is a big obstacle. I would say that 99 times out of 100, when somebody tells me about pain, somebody in their life who's tired or stressed out or whatever they are is going to say, he's just doing that for attention, ignore it. But it turns out to be useful, even if, as we talk, they say, well, I don't really have a bad headache, but I do this. It's the ticket to admission. I hurt. Okay, tell me why you hurt. We have one person we're working with literally right now, and this is August 2023, where she's been in the hospital being evaluated every day, almost, for the last 3 months. And every single time she goes, the docs say, this is misuse of our resources, there's nothing going on with her, send her home. And they finally let us take a look at her blood results. Well, it looks like she's got some terrible, terrible medical problems going on that nobody's treating. And they were all things that could have been caught months ago when all this started. And they're all painful conditions. So maybe she's not really just being behavioral, right? The other mistakes and obstacles, escalating punitive, coercive, controlling programming, or heaping on a bunch of sedating medicine. Instead of saying, wait, stop, this path is the wrong path. We got to stop and reevaluate, get more information. So SD, the man we were talking about. Well, we look a little bit more closely. Turns out he's having a bunch of hallucinations. Looking at the empty spaces, interacting, scared, responding. There's a lot of reasons people have hallucinations, not just a major mental illness. There's all kinds of other possibilities as well. Well, this thing, where he does this, holds his head and looks sad, what might that be? Well, would it be of interest, for example, that his mother, father, siblings, cousins, aunts, uncles, and grandparents all have migraine headaches? Yeah, I think that's probably pertinent, isn't it? So just start him on a dab of medicine to prevent migraines. And this and the head banging stopped. He has recurrent H. pylori bleeding ulcers. They were in his gut so long that the chances of him never having another H. pylori ulcer are very low. And in fact, each time he's having a flare of H. pylori, he signals this by overeating to the point of vomiting. Yet even in current times, somebody noticed the overeating and vomiting, and their first instinct was to just restrict his access to food. Nah, that's not what's going on with him, is it? He had an anal fissure, and there is one medicine that has consistently worked to heal it. And every time somebody says he's digging at his rectum again and there's blood, I'll say, is he still getting brand name Anusol? Oh no, we ran out of that, so the pharmacy gave us generic. I'm like, no. And he's got allergies and stuff. Isn't this enough? Are we done yet? Well, he feels better, but he's still got big stuff going on, right? So this is one of my favorite moments ever in working with people. So Ruth, I've been in this field for 20 years, and I've never smelled urine like this. This was a DSP working for this man, SD. So he didn't know what it meant, but he knew it meant something. So he and I went and sniffed his urine, and sure enough, it was a very, very particular characteristic aroma for an extremely rare blood disorder called hepatoerythropoietic porphyria. Yeah, I know, that rips right off the tongue, doesn't it? Well, the thing is, hepatoerythropoietic porphyria causes odd-smelling urine, abdominal pain, hallucinations, agitation, and the treatment is high doses of sugar. Yes, the guy who wants 2 dozen popsicles a day should not be leveraged to try and earn them. Those are his treatment. And in fact, people with this type of porphyria, and he turns out to have a very severe form of it, need to eat the equivalent of 1 pound of sugar a day. What do you think about plans that just, in a very blasé way, say, well, that much sugar can't be good for a person, instead of saying, no, wait a minute, why does he need this? He also had mastoiditis, which is that spongy bone that cups your ear on either side. Well, if that gets inflamed, people feel kind of sick and dizzy. And one of the ways to manage that is to either swing or go on car rides. That soothes that sick, dizzy feeling that you get from mastoiditis. The guy who gets very upset when he doesn't have access to his swing. And he had a bunch of complications of this. So we treat all this stuff that presented all these sideways sorts of ways. Does it matter? That's a big question. And we get this kind of pushback when we say, well, he needs this test, and he needs this test, and he needs this treatment. The pushback is, well, does it make any difference? Well, some of you know this man because he's one of the easiest people to support in the whole company. There's no serious injury to himself or anybody else. He doesn't destroy things anymore. He's smiling and peaceful and a goofball most of the time. Great big flirt. I mean, he gives all those bedroom eyes to everybody. Just adorable. He no longer poops or pees any place except his bathroom. He's able to have long, fun visits with his family now. His parents have been able to go on vacations. And now, without any prompting or anything else, he's starting to use spoken words and sign to communicate. And he just keeps getting happier and happier. So for him, all the medical stuff got treated, and you say, well, are we done? Well, at the moment we are. But when people are still oriented towards, we're going to stop inappropriate behavior, we still have to be vigilant, because somebody will come in and say, he shouldn't be able to have 2 dozen sugary popsicles a day, or somebody else will make a pronouncement like that without thoughtfully saying, now wait a minute, there's a reason why this is in his life, and we facilitate this. He started to have some more abdominal pain recently, and so we could have just said, well, he does have a history of ulcers, and he does have porphyria, so maybe he needs more sugar, needs to have the ulcers treated. Well, yeah, that helped a little, but he still had pain. Now he has gallbladder disease, which is a complication of porphyria. It's not his fault. Nobody did anything wrong, but he's going to need treatment for that too. So always vigilant. Is that like the motto of some important agency? So Mary, we're going to talk about Mary. Mary's 50 years old. Mary and I are exactly the same age. So I met Mary 12 years ago, which makes me 62. And when she and I first met, when she was 50, I'm going to show you some partial pictures that don't show her face because of videotaping issues. But she was referred because she kicks, bites, or spits anytime she's seated in her custom chair. She's not walked before in her life, so she does use a chair to get around. She's getting Abilify, Klonopin, and Seroquel that are supposed to make her quit kicking, biting, and spitting anytime she's in her chair. She happens to also have cortical blindness, which doesn't seem to cause her any anxiety because she's about this big and a total powerhouse, 80 pounds of pure power. And gives you an idea of the situation she was living in. She likes to drink a margarita And the case manager proclaimed that since she has profound intellectual disability and doesn't use speech to communicate, she's not allowed to have any alcohol. What? 50 years old? You're going to tell her she can't have a drink? So this is Mary crouching on the floor, which she would do. This is my old office, 12 years ago. That's her brother's knees behind her. Her brother and her sister are very, very close, very, very involved with her, thankfully. She slips out of her chair and crouches on the floor. And you can't probably make it out all that well, but her back is very, very stiff. And the other thing that she does consistently is presses herself onto the floor, presses her whole abdomen onto the floor, like that. And we'd been told that this was just some factor of profound intellectual disability. Nobody was thinking that meant anything, except her brother and sister, who said, we thought there might be something to that, so we got her primary care to order some x-rays and some imaging, and the primary care said that they were unremarkable. And this was in the first visit, and here we're having the second visit. I said, well, I'd like to see the actual reports from the radiologist. And they're saying, well, he said they were unremarkable. So what do you want that for? I said, just humor me and bring them. And sure enough, they brought them on the second visit. And I'm, of course, crouched down there on the floor with Mary. And I'm looking at these reports, and Mary's not all that interested in me. I can accept that. That's just fine. But when I said, Mary, I think there's some stuff on here that might be important, she popped up to a seated position to listen to what I had to say. And it turned out that the imaging showed that she had Harrington rods placed in her spine when she was really, really little, like 2 or 3 or 5 or something like that. Oh no, when she was 15, they put the Harrington rods in her spine, and she's 50 years old and they'd never been checked. The bottom part of those steel rods had come untethered and was scraping back and forth across her pelvis and lower spine. And the abdominal imaging showed that she had a mass on her ovary this big. Unremarkable? Beg to differ. So again, do I sit and explain all this to Mary? Of course I do. Does she understand every word I say? I don't know. I don't think most people understand every word a doctor says to them, but hopefully they will understand respect. So we discussed all this, and then her sister, the most amazing sister on earth, scrunched down next to her and said, honey, we're going to get this treated. I think she had a good reaction to that. And so she did. The back problem was addressed. The mass was removed. I circled back to the doctor who said this stuff was unremarkable. And he said, well, those kind of people don't really feel pain, do they? I'm like, this is in this century too. And he said, and the mass on her ovary, it didn't look like cancer or anything. Well, yeah, but that stuff hurts. It takes up space. There's not much real estate there. She's like, this big. So over then, we took her off all those medicines she was taking. She instead takes a little bit of pain medicine for arthritis, but the Abilify, Seroquel, Klonopin, that's all gone. And 2 years later, Mary was able to stand, to walk, and to dance. A year or so later, Mary had a stroke. She's lying in the neurology intensive care unit, and you already know the enormous, enormous strength of character she has to learn to do those things in her early 50s for the first time. She's utterly vulnerable and helpless. And the neurologist starts to pressure her guardian, her conservator, her sister. People like this don't really have any kind of life anyway. Don't you think it would be kinder to just let her go without treatment? Thankfully, people were right there at the bedside to put a stop to that kind of talk right this minute. And it's part of the reason I strongly, strongly, strongly recommend that any people with IDD who are in the hospital have somebody there with them at all times to help advocate. So Mary got treatment. She recovered. She took up some new sports. Her balance is a little off. That's why she's got the navigator, but her strength is still quite good. Took up a new sport. Took up another new sport, riding horses, first time ever. Came to visit me at one of my other offices. And as you can see by her beautiful smile and her strength, she's fully recovered from that stroke. Her smile is perfectly symmetrical. And this is Mary training for a race. Now, as I mentioned, Mary and I are the same age. And the most recent update is that Mary celebrated our 62nd birthday with family with a sparkly top that I really got to have. She, I think, illustrates some of the really essential points of healthcare and health issues access, is that there's widespread discrimination, a tremendous tendency to underestimate how well people can do, and an increasing unwillingness to even give people the opportunity to get well. And part of our job needs to be to stand with people and advocate for them, for their opinion, whatever it might be. And Mary made it clear in every way she could that she still's got stuff she needs to do. She ain't ready to go yet. We talk about the elements of success and quality of life. We talk about body, mind, soul, and situation. And as I've mentioned in other trainings, I think situation is something STEP does better than most organizations I've ever seen. Soul, mind, and body. And these are aspects of a person's life that influence all kinds of behavior, not just the ones that get noticed, injury, self-injury, failure to thrive, but some of the more subtle kinds of activities as well. For example, in the last few years, I've seen a tremendous increase in the number of people diagnosed with dementia without any evaluation. There's a million jillion different ways. That's a good scientific term, don't you think? Million jillion. There's a million jillion different things that can cause a person to lose function that can be treated, and the person can get the function back. But you gotta look. Of the hundreds and hundreds and hundreds of people that I've seen over the years that have been referred to me as losing function, losing their memory, losing skills, probably dementia. Those are the way the person's billed. Exactly 2 have had an irreversible dementia where they were going to lose skills and there was nothing anybody could do about it. All the rest of the people have had a treatable reason that could reverse the loss, so people would get back their skills, their interests, their memories, and so on. It just takes a little work to figure it out. So what are the different ways that biomedical conditions influence more overt behavior? Not detouring into the overdiagnosis of irreversible dementia, but back over into talking about self-injury, aggression to others, property destruction, failure to thrive. Well, the first mechanism is the one everybody thinks of, but it's actually the least common mechanism. Any of y'all visited Boulder, Colorado? The People's Republic of Boulder, Colorado. I practiced in Colorado for many years, and I loved getting referrals from Boulder because they were so respectful. Sometimes the respect was so fabulous that we had no idea what was going on. For example, there was a fellow named Tom who reportedly had severe autism, profound intellectual disability, no meaningful speech, who was reported to have potentially self-stigmatizing alternative methods of self-sexual expression. Pretty much no idea what all that meant, but we figured with that many euphemisms coming from Boulder, it had to be truly scandalous, so we couldn't wait. So my little team and I, we jumped in our little vehicle and dashed off to Boulder. So we're on the phone with the service coordinator, case manager it was the name in Colorado. He's got severe autism. How can we see him without being, toxic and disrupting his schedule and, messing up his environment? And she said, oh, no, you don't need to worry about that. He really likes change. Meeting new people is his favorite thing to do. He's always like that, and he's always done it really well, and it's really comfortable for him. He's never had any problem with socializing at all. He doesn't like routine. He doesn't like doing the same thing. Well, what is it that he actually does? He walks into his house, you'll see the autism. He walks into his housemates' bedrooms at night, grabs at his own genitalia, and hoots, potentially self-stigmatizing alternative methods of self-sexual expression. And a guy with a really interesting, socially comfortable, dislikes routine subtype of autism, right? So we get out to see him, and I look into his eyes, I hold out my hand to shake hands, and he looks back at me and he says, "Suck me," and jerks all over his body. What's he got? Tourette syndrome. Misdiagnosed as autism for 25 years. Now, most of the time, actually, Tourette syndrome is a really benign condition. I worked in a Tourette clinic when I was in medical school. Coolest waiting room ever, just saying. And one of the things that I learned is that for people with Tourette syndrome, the ones who really, really enjoy their lives are the people that develop a sense of Tourette pride. It's like, the public just has to get over it, which is, in fact, very doable, very possible. However, Tom was diagnosed with severe autism based on two big errors. First, they failed to recognize that his autistic-like mannerisms were in fact tics of Tourette syndrome. And second, they failed to take into account his interests and strengths. If they had been paying attention to him as a full person, they would have said, he doesn't have autism. He's got something else. And if they were really thinking, they would have said, well, all these twitches and tics and noises and things don't hurt anybody, do they? Right? Now, I've met a couple of people with Tourette where they had really dangerous tics. One man had a neck twist tic, and he was going to sever his spinal cord if we didn't do something about that. So he decided on some medicine for that. Another guy had a tic that involved smashing his skull into things, and he'd actually tripled the thickness of his skull and had a brain bleed. So we had to do something about that. Those are very, very rare examples. In fact, most of the time, Tourette syndrome is a very benign condition, and it's not even that distracting if you work properly with the person. The coolest thing ever, I think, is to go to a great big Tourette Syndrome Association international meeting where they get all these people together with really out and proud Tourette in these echo chamber ballrooms. It's the most coolest thing ever. It's the perfect desensitization exercise. Tourette's differs from other conditions in one simple way. It's a disease of the onlooker. I mentioned Tourette. Oh, by the way, what was the correct thing to do for Tom? Teach him about Tourette so he didn't spend all of his energy tying himself in knots. That's why he didn't speak or engage with people. That's why he got misdiagnosed as having a profound intellectual disability. It turned out that he, when he didn't spend all of his energy trying to avoid getting punished or reprimanded for his tics that were misdiagnosed as autism, he shouldn't be reprimanding autism either. Talk for another day. He turned out to have an average IQ, and he discharged himself from services. And I thought I was never going to hear about Tom ever again. But I was giving a presentation to 400 hungover nurses at the Developmental Disabilities Nurses Association meeting. And I was talking a little bit about Tom, and Nurse Nancy from Boulder, Colorado was in the front row saying, I have follow-up on Tom. She had referred Tom, potentially self-stigmatizing alternative methods of self-sexual expression. She stood up, and I have follow-up. Tom now attends my grandmother's church, where the average age of the parishioners is about 89 and a half years old, and they're all little, fierce, white, blue, or lavender-haired little ladies that are small and fierce, best kind ever. And they love Tom. Now, Tom, as I mentioned, very social, loves to help people. They love Tom. He loves helping the ladies with whatever, their homes, their gardens, et cetera, et cetera. He's got, more odd jobs than he knows what to do with. And when Tom comes to church, he makes an entrance. He has learned that shaking out some of his tics ahead of time helps him be able to enjoy the church service more. So he will walk into the church and walk up and down the aisles, waving his arms, saying, "Shopping for pussy, shopping for pussy." And then after a couple of rounds up and down the aisles, he would be seated and enjoy the church service at this church where they love him. Well, the time came when the ladies were going to call a new pastor. And they decided that the way they would audition them would be to have them do the service on a day when Tom's going to be there. Now you can just imagine this brand new, newly certified pastor is going to present the service, celebrate the service, on a day when Tom's going to be there. And everybody wants to see what he's going to do. So the church is a sea of white, blue, and lavender hair. Tom makes his entrance. Shopping for pussy. Shopping for pussy. And ladies, "Hey, Tom, nice to see you." Looking at the brand new baby minister. "What are you going to do with that, buddy?" And he looked out over the congregation and said, "Aren't we all?" And he did get the job. For movement differences, which are often absolutely benign, this is a situation where the actual physical movement of the activity is directly caused by their neurological issue. The first question to always ask is, most of this stuff is pretty benign. Why are we even bothering with it? Why are we telling people with autism they can't do this? Why are we telling people with autism they can't rock? Why are we telling little kids with autism they can't walk on their toes? What are we thinking? What a human rights issue this is. And I remember that behaviorist guy, the hot guy that I got married to, that's admits to being a BCBA, PhD, blah, blah, blah. Well, I like to eavesdrop while he's doing his continuing ed courses. And the coolest ones are BCBAs with autism presenting on what they think makes sense in terms of programmatic support to people with autism. Very different perspective. If our job is to help people be healthy, happy, and successful, then we should not be trying to make people invisible, right? People with Tourette and other movement differences remind us of that. Remember when we talked about trauma-informed support, loyalty. Loyalty. How do I look in public? Are you going to give me a bad time about it? Because if you are, then you're rejecting me, you're denying me, and I can't trust you. Other biomedical conditions that directly can cause the activity of concern, certain very rare subtypes of seizures can do that. It's very unusual, but it happens. And this mechanism, as you can see, because I don't have many examples, is the most uncommon reason health issues influence behavior. And unfortunately, many evaluations just stop there. And that's not good because all the other mechanisms occur much more often. For example, little dude, he's 7 years old. He was referred for sudden onset autism when he was 6 years old. What do you guys think about that? Do people start to get autism suddenly when they're 6? He also had episodes of confusion, homicidal impulses, and hallucinations. All of this completely out of character. And he was on the verge of being expelled from school because of their zero tolerance for threatening statements policy. So what do you think? Should we just say, yeah, he just needs an autism behavior plan? When you visit with him, you discover he's got some skin changes called vitiligo. Vitiligo is a clue that a person may be vulnerable to autoimmune disorders like lupus or rheumatoid, or in his case, Pandas syndrome. It's a very controversial condition, but when a person has it and they get treated, things change. He'd already been heaped up with a bunch of psychotropics that didn't do a thing for him. But we started him on the treatment of Pandas syndrome, which is 1, 2, or 3 antibiotics. So the kind of medicine you get for strep throat. 1, 2, or 3 antibiotics every day until your immune system matures, which in his case was for the next 10 years. Within 2 days of starting the antibiotics, all the activities of concern went away. He graduated as an honors student, musician, and has a career in repairing large engines. The mechanism by which the Pandas syndrome altered his behavior was not a direct one. It caused confusion. Sometimes he wouldn't know where he was or who he was. And by causing extreme mood changes. And there's many examples of all of these. Infections or inflammations in the brain from other reasons. Thyroid problems, blood pressure issues, medication side effects. A buddy of mine was just in the hospital for quadruple bypass surgery. The only problem he had was that somebody gave him Pepsid to prevent stomach acid, and for him, Pepsid caused him to have hallucinations. It's just a stomach medicine, but for some people it causes terrible neuropsychiatric problems. The group of medicines that does that is Pepsid, Axid, Zantac, and Tagamet, also known as famotidine, nizatidine, ranitidine, and cimetidine. So if you have somebody who's taking those and they seem to have psychosis, switching that may be one of the things to do. Might be. And causing intense mood changes. This sweet little kid was suddenly overwhelmed with rage. Well, it's because he had this Pandas pediatric autoimmune neuropsychiatric disorder associated with strep that was causing inflammation in the amygdala, that central part of the brain where unreasoning rage lives. 2 more mechanisms. Now, here's another mechanism. Okay, I'm going to say a bad word, but I'm quoting somebody else. So if I offend you, I apologize in advance, but I am quoting her words. Connie, 50 years old, delightful human. Worked with her years and years ago when I lived in Colorado. She would come by the office for her appointments. We'd do the medical part. She was on a little bit of an antidepressant and doing extremely well, full-time job, good romance, good life, good friends, blah, blah, blah. And so we'd get the medical part out of the way, and then we'd pretty much just get up to speed on all the smut from everybody in her whole life, which was really fun. So I was very surprised when she walked into the office, punched me in the face, and said, "Stop fucking my boyfriend." Now you go, there are many thoughts that run through a person's mind, right? But the first one is, this is so radically different for her, something's wrong. And so she's not really responding very clearly to questions. Well, how does she look? Well, she looks really flushed and hot. Well, what's some really simple information we can get right there on the spot? Well, does something hurt? Yeah, my head. Doesn't cost anything. Check her vital signs, right? Temperature's normal. Blood pressure and pulse were not. Pulse was slow, 50 or so. And her blood pressure was 300 over 270. So the next phone call is not, we've got some gal with a delusion who just popped her psychiatrist. Because if we call that in, what are we getting? We're going to get police and restraints and that kind of business. What we're going to do is call and say, we got a gal here who is having a stroke, or will have a stroke if we don't do something right away. Sure enough, she had malignant hypertension, and it spiked up that day, caused her to have hallucinations and delusions, and she was defending her turf as her brain told her to. Now, what if we just called in and said, this gal she's delusional and she punched her psychiatrist? What would have happened to her? Well, if she'd survived, she would have landed on a psychiatric unit, and heaven knows when somebody would have gotten around to checking her blood pressure, right? It turned out that this had in fact happened to her 10 years before I knew her. She'd had an episode where she walked in on her psychiatrist, said something that was very, very psychotic and delusional, and punched him. And they didn't do any evaluation. They just called for the ambulance. And she had a stroke about an hour later. She recovered from that stroke, but people, another one would have been harder to recover from. Simple things we can do right on the spot, particularly when somebody has such a sudden change in how they interact, right? In this case, it caused her to have psychosis. Well, what about Carlos? Carlos is a guy who's 46 years old. I didn't actually know Carlos professionally. I just knew him to know what he looked like because I was working with his roommate. He had a housemate that I offered some services to. Now, this is back in, the Jurassic Park era, before we had any such thing as cell phones or video phones, so I couldn't just say, pop him up on FaceTime or, let's do a quick Zoom or something. And he lived 2 hours away from my home. So even if I were to jump in my car and go see him, it was 2 hours. Well, the staff there, excellent staff. They called me and said, Ruth, we know you never do this. What is it? I never prescribe for somebody that I've not assessed, or I've never prescribed a new medicine for somebody without doing some kind of assessment. But you've met Carlos. Carlos is a peaceful guy, and he's beating people up, and he's never done that before. He's 46 years old. We love this guy. He's beating us up. Ruth, could you give us permission to give him a little bit of Ativan to settle him down while we figure out what in the world's going on? Now, these are really good staff. I could see why they'd ask me such a thing. And they know I respect them enough. But am I going to do it? Nah, I shouldn't, should I? No. So I said, well, what's he look like? What's going on? Did something happen? Well, these are good staff. If it was something obvious like, a death in his family or, some other terrible thing, they would have understood that and I would not have been called. They would have just helped him through it. But no, he's punching us. Well, okay. Can you get vital signs? Nah, we can't get that close. Well, is he talking about pain? By the way, Carlos also communicates without speech, right? So, but they still ask. You always still ask. Carlos, does something hurt? And you give him kind of a look, and he just keep punching us. Well, you can't get close enough for vital signs, but well, what does he look like? Well, he's breathing really fast, and he's drenched with sweat, but he looks kind of crappy and gray and awful. Oh, that's not good. And so what happens if you get out of the way? The people he's punching, well, he's punching his two most favorite, most beloved staff members. And when they step away and we try and get in between them, he goes around them to punch those people. Well, if he can be that deliberate, then it's not a seizure. Where on their bodies is he punching his two most favorite trusted staff? He's punching his two most favorite trusted staff in the middle of their chests. Drenched with sweat, short of breath, looks gray and crappy, and the best way he can think of to tell us where he hurts is to show us where it hurts. So the phone call is not 911, we've got a guy with a developmental disability who's beating up staff, right? That's not the call, because what are we going to get? Right? The police, the cuffs, the restraints, all of it. The call is, we got a guy who's having a heart attack, and we need the cardiac squad right now. Now, what if we'd been wrong? What if we thought all that, and it turned out there was no heart problem? It was something else. Well, that happens a lot. Lots of people go to the emergency room with chest pain that thankfully does not turn out to be a heart attack. But what if it is? Well, that's what they did. And a good thing too, they couldn't, what if they'd waited for me to get there 2 hours? What if we'd given him a little Ativan to settle him down? All of those have a very bad outcome. Instead, he got treated for what turned out to be a massive first heart attack, and he, in fact, survived another 10 years, which was amazing because I didn't know this. I didn't know him professionally, but all the men in his family typically died before they turned 45 of their first heart attacks. So he actually outlived his family prognosis. So the other way, and this is one of the most common ways that people express pain, is through changes in how they behave. And there's a bajillion different ways people can be in pain. It's not obvious on the outside, and deserves that really thorough evaluation. And when we talk about nonverbal complaints and clues, that is, things people do because they don't have the words, we'll be talking about a lot of different ways invisible pain can be brought to awareness and understood. By the way, is it okay to just ignore pain? Is ignored pain, a benign thing? My goodness. What happens if a person's in pain? Right? it accelerates the onset of cardiovascular disease. So a person who was probably going to get coronary artery disease in their 70s, if they don't get pain relief for chronic pain, they'll have it in their 50s. Shortens people's lives. Impaired immune function, altered immune function, suicide, depression, trauma-type changes in the brain. And it can be to the point where untreated pain can cause people to have hallucinations and delusions. It's really, really miserable. And there's so many ways to treat pain other than only pills. And it's up to us to offer people every single possibility and option as a way to improve their life and extend their life. And the last mechanism is illustrated by a little dude named Jacob. Jacob was referred to me by a very, very interesting family situation. They wanted a better behavior program because everything they did for this child, he refused. He refused everything. If I could show you his picture, it's a school picture where he was asked to smile, and instead he went like that when he was asked to smile. And they'd offer him every different kind of version of Disneyland that you could imagine, and he would just refuse, start and stop. I mean, the thing that was even more sort of troubling and a source of resentment for his parents is that his mother was a doctor, his father was a nurse, and the kid's pediatrician was a close family friend from medical school whom they 100% trusted to have evaluated for any kind of health issues. So I'm like, why are you bringing him to me, right? Well, we know you have behaviors working with you. And they were truly incensed when I said, well, bring all the medical stuff. Well, we've got the letter of medical clearance from our friend. I said, yeah, I know, but I want the lab results anyway. Well, when you got past the smell to fart look that this child had, you noticed there was something not quite typical about his face. He was 6 years old, yet he had the nose of a toddler. His ears were in the wrong place, and they were tilted back. His hairline was way down here. And if it had been about 300 years ago, we would have noticed in a heartbeat that what he probably had was congenital low thyroid, congenital hypothyroidism. You know, the thyroid, the gland in your neck that has to do with everything in terms of growth and energy in a person's whole life and body. Well, we all get screened for this at birth. That's part of the reason we all get screened from this, is because it's so treatable. Well, we did all the things you're supposed to do. That's what the parents said. I'm like, why are you bringing him to me? Well, I said, and they said, here's the labs. And I looked at them, and sure enough, this little Jacob had been screened for thyroid 3 times, and all 3 times the test was abnormal. That had just been missed. So 2 important things. First is that we can't rely on anybody else's interpretation of an objective piece of information. So when we do assessments together for people, comprehensive assessments and such, I will be asking for the actual lab reports and the imaging reports, not somebody else's interpretation of them. And the second thing is that it's very, very sophisticated, very well-off family. There was a sort of a resentment that what was going on with him could be something so ordinary. But they clearly got over it. He got treated, and in fact, a few years ago, he finished graduate school in neurophysiology, of all things, oddly enough. Jacob illustrates the very last mechanism, which is that if something's simmering in a person's health and body, that will take up energy so that nothing else you offer is going to really help very much. Untreated pain, untreated low thyroid function. We've got a brand new gal in the enhanced unit that has a whole bunch of hormonal stuff going on that until we treat that, she's really going to have a hard time benefiting from all the other things that are being offered for her. So the most common mechanism is not a direct one at all. It's that these untreated health problems make it impossible for all the good stuff to help the person as much as we'd hope. So it's critically important, essentially important, that the people who work directly with individuals every day pay attention to every single thing you see. You know, I don't understand why he got gray so fast. I don't understand why he's got these white patches here. I don't understand why he's got this, you know, when I help him change, he's got this big blobby mass next to his testicles. Oh my goodness. All these things you notice that you may not realize are important, almost always are. So don't keep it to yourself. The mechanisms by which health problems influence a person's behavior, the direct causation, where the problem causes the physical movements of the activity, it's the first one everybody thinks of, but it's actually the least common mechanism. These other mechanisms, easily mistaken for psychiatric symptoms, purely psychiatric symptoms, but in fact they may originate in other parts of the body besides the brain. Delirium, confusion, mood changes, hallucinations, delusions, pain, and conferring treatment resistance. Your observations are essential. It's important to always remember that if a person has serious enough activities of concern to be in enhanced or a mobile crisis service or basically coming to clinical attention, the underlying causes are almost always medical, usually more than one. You probably pick up the clues before anybody else. Don't be put off by doctors who are dismissive. We just can't let ourselves be distracted by that. And every idea you have is important and welcome, and you're incredibly appreciated. Thanks for listening.